Thanks, Nicola. Good afternoon, colleagues, and welcome to this afternoon session. We will think we have enough people in the room to actually start. So this afternoon, we will be presenting from our side here at UKZN and in Kosi Albert Lutuli Hospital. Our topic is from on thalassemia major, transformation to transfusion, curing thalassemia. So it'll be myself presenting some cases and our fellow Dr. Jasmine Ramiah will be presenting the theory behind it. So, so as I said, today's session is brought to you by Blood SA in conjunction with the University of KwaZulu-Natal, the South African Haem Society, and the South African Stem Cell Transplantation Society. This is the deep dive management team, and a big thank you to Prof. Stel Verberg, Dr. Nicola Smith, who celebrates her birthday today. A happy birthday to you, Nicola. We wish you all the best, and thank you for all that you do to make this possible every week. And we have Mrs. Michaela Brooks, who's the administration person in charge of administration. Some housekeeping notes. All these sessions are recorded and can be found on our website, bloodsa.org.za, under resources, deep dive. Please mute yourself during the presentation. Feel free to add any questions or comments to the chat box, and we'll respond to them at the end of the presentation. CPD points will be submitted to the HPCSA for each registered South African attendee. So please ensure you're attending with your own registered Zoom link and not in a group. You must attend for at least an hour to qualify for these points, and ensure that your HPCSA number is entered correctly when you sign up for deep dive. If you have any queries or would like to request a CPD certificate for another council or country, please email admin@bloodsa.org.za. You can join our mailing list via our website under resources, subscribe to Deep Dive, or use the QR code that appears on the screen. We value your feedback, so please complete the anonymous feedback survey at the end of the Zoom meeting. It takes just a minute or so, in fact, under a minute, so please, we would appreciate your feedback. So some important upcoming events. The Physicians Conference is being held from the 4th to 6th of June this year in Stellenbosch. So for those that are interested, please note the early bird registration has already passed, but please, you are welcome to use the QR code and sign up for this conference. Then importantly, the SASMO-SASIS conference is being held from 7th to the 9th of August. At Sandton Convention Center, we'd appreciate people joining this conference, and also for those from academic centers or even from private centers, there will be abstracts actually opening up soon. So please, we'd love to see your research, your posters, any sort of work that's being done in South Africa can be showcased at this. And then on the 2nd to the 4th of October, the Haem Onc conference is being held in Cape Town. Here too, you can start preparing for your abstracts and your research. We also would appreciate this is a very exciting meeting as well, and we'd love everybody to actually come attend. Next week, our speaker is Dr. Stel D. Chu. It's an international speaker. We'll be covering American Society of Hematology 2020 guidelines for sickle cell disease, focusing on transfusion support. So this is also very, very interesting topic. So please, everybody, join next week. So today, as I said before, sorry, let me just put my phone on mute. I will actually be presenting a few cases that we've treated in our center, followed by Dr. Ramiah's talk on the theory behind thalassemia. They're followed by questions and answers. So as we are going through, I would appreciate if you could put in your questions and comments in the chat box, and we will get to it as the talk's going through, and we'll attempt to answer them. So before I start, I just want to introduce Dr. Jasmine Ramiah, who is a fellow at our hospital in Nkosi Albert Lutuli Central Hospital, where her passion for hematology first took root in 2016 when she joined us as a medical officer. She subsequently expanded her expertise, specializing in hematopathology with the NHLS, and she qualified in 2024. And we're happy that she joined us in our unit as a clinical hematology fellow. And she's deeply committed to equitable patient care, has a special interest in transplant and management of acute leukemias. She also serves as an associate lecturer at the University of KwaZulu-Natal and actively supervises multiple research projects. And beyond academia, she contributes regularly as an author for Oncology Buddies magazine, where she bridges clinical and science with patient-centered storytelling. Jasmine is a proud boy mom to two spirited little soldiers and the wife of an orthopedic surgeon. When she's running hematology services, whether she's running hematology services across KZN or competing in road races, she approaches it all with purpose, heart, humor, and humility, always honored to serve where science meets soul. Okay, so I'm going to share my slides now. And I'm going to sorry. Okay, can somebody confirm that you're seeing my slides? And then
Yes, we can see them.
Okay, I just want to shut my video off. Okay. So once again, good afternoon, everybody, and thank you for joining us today. So if we look at thalassemia major globally, its distribution tells a story not only of genetics, but also of history, malaria, and human migration. For centuries, thalassemia has been concentrated in what is known as the thalassemia belt. So this includes areas of the Mediterranean, Middle East, South Asia, and Southeast Asia. And the reason for this distribution lies in evolutionary history, because thalassemia trait confers a selective survival advantage against malaria. And in areas where malaria is endemic for centuries, individuals carrying thalassemia mutations were more likely to survive childhood. Over generations, this has resulted in high carrier frequency within these populations. But these diseases do not stay confined to geography, and human migration changes epidemiology. So today, thalassemia is increasingly diagnosed in countries that historically had low prevalence rates.
Sorry, the slides aren't advancing.
No, I'm just giving a bit of a background. So before I move on to my next one. So why I'm talking about this, just to give people perspective. So today, thalassemia is increasingly diagnosed in countries that historically had low prevalence rates, and these include the United Kingdom, the US, Canada, and Australia, and even South Africa. And In most of these countries, the disease actually occurs in immigrant populations or descendants of populations originating from these thalassemia belts. And so this is what brings us to KwaZulu-Natal. The story here begins in the 19th century during the period of British colonial rule. The British controlled both India and parts of Southern Africa. And in 1960, the first ship carrying Indian indentured laborers arrived in Natal, now KwaZulu-Natal. And these laborers were brought primarily to work on the sugar plantations. Over the following decades, thousands more arrived from different regions in India and bringing with them their cultures, language, traditions, and unknowingly their genetic heritage. And then later waves of migration included Indian traders and merchants who established communities across the province. Today, the descendants of these communities form one of the largest Indian diaspora populations outside of India, particularly concentrated in KwaZulu-Natal. And because of these ancestors originated from regions within the thalassemia belt of South Asia, the carrier frequency of beta thalassemia is higher within this population than in the general population. So this is where our story starts. So our first case is actually one of the patients that is our longest surviving thalassemia major patient. So she was born on the 24th of December, 1968. She was diagnosed with thalassemia major at 3 months of age and was actually initially in the private sector. Her family was informed that her treatment would eventually become unaffordable, and she was thus referred to the state sector around the age of 3. At the age of approximately 4 years old, she had a massive splenomegaly, and this was causing her extreme discomfort, which required that she had a splenectomy. Unfortunately, this was complicated by severe surgical sepsis and took her a long time to actually recover from this. So once she recovered, her father, I actually interviewed her last week before I actually presented this, and she gives a very endearing story about her father, who she credits for the commitment to her care. And he played a major role in actually advocating for the thalassemia patients in KwaZulu-Natal. And through the engagement with the Department of Health at that time, he helped to obtain approval for iron chelation therapy with desferoxamine, also known as Desferal. Importantly, the community in which she grew up and the community at large, the Indian community at large, actually raised funds to purchase approximately 20 infusion pumps used for Desferal infusions for other patients aside from herself. Her father went on to be one of the founding members of the South African Thalassemia Association, which currently is still running and still advocates for patients with thalassemia. So at the age of 18, when she entered university, she developed diabetes. And this was one of the complications of her iron overload. So despite her being receiving iron chelation therapy, remember she started quite late with the therapy, and she had already developed complications from iron overload and had dysmorphic features and stunted growth. Um, Over the years, she developed multiple additional complications, including osteoporosis, other endocrinopathies, and cerebrovascular disease, and suffered a stroke. Despite these complications, she remains highly functional and a professor and has actually returned to lecturing. In 2015, we fortunately, with the help of Novartis, was able to um, we began actually doing ferry scans in T2 stars to assess patients' iron overloads status. And this was her ferry scan. So unfortunately, the program closed after 2018, and I just decided to show some of the scans that we had received. So as you can see that in January 2015, she had her liver iron concentration actually was not bad. She had it was within range, and you can see at 1.8 milligrams per gram dry tissue and 32 millimoles per kg dry tissue. So that was within range. And then when you compare this to January of 2018, you can see that this had increased to 4.5 and 80. And these were her cardiac MRIs from 2015 and January 2018. And one needs to look at the reference ranges for those that have not looked at these sorts of reports before. And one needs to look at the T2 and your R2. So T2 more than 20 means that there's no iron deposition, R2 less than 50. So you can see that she fell within the range of no iron deposition. And again, one can see in January 2018, she did still was in the safe zone of having no iron deposition. So her current status, she's now 56 years old. She's still lecturing at the university. She receives chronic transfusions. She receives 1 unit every 3 weeks. She's now been changed from X-Jade to Jade New, which are both are formulations of the ferrosirox, and she's visiting her endocrinologist regularly for her multiple complications. And as I said, in 2018, she had a CVA. She does have residual left-sided weakness, which she now does not drive any longer, but is able to walk and she's functional. She does have mild sensory neural hearing loss, which is one of the side effects of using ion chelation therapy, and still has a relatively good, and we are unfortunately unable to do the T2 star and ferry scan anymore, and we've looking at ferritin still, and she has relatively good ferritin. Our second case is also an Indian female. She was born on the 9th of March 2000 and was diagnosed as well in childhood and initially managed by our pediatric services. And at this point, I just want to stop and give huge credit to our pediatric colleagues. When I started my career in hematology in 2002, I obviously was working in the adult services, and we had inherited these patients from, the adult patients who obviously already iron overload, but the pediatric unit had the children who were now having the benefit of receiving chelation therapy, and a lot of these kids actually have grown up to be have minimal dysmorphic features and actually look I'll have fewer complications. So just to show that it really has, I have seen the difference in my career as the children have transitioned from pediatrics to adult care. So with regards to our girl, she was 11 when she presented to the pediatricians at our hospital with acute pancreatitis, and she was managed conservatively at that point, and she was already receiving iron chelation therapy with both Exjade and Desferal. She subsequently underwent a cholecystectomy. And then in November 2014, she also had her MRIs done, and again, one can see that she had her T2 star measurement was in this second category. So her T2 was 15.7, which meant that she had some iron deposition. There's little immediate risk of iron-induced cardiac decompensation. At this point, the pediatricians were actually giving her IV Desferal, and Jasmine will talk about the shuttle effect of that. If you look at her, she also had some iron overload, as you can see that her range was above the normal upper limit of normal. So at age 12, she was referred to our unit for evaluation for an allogeneic stem cell transplantation. She had a matched sibling donor, her brother, who was a thalassemia trait, and she underwent transplantation in July 2014. And she was conditioned with Busulvex, melphalan, and cyclophosphamide, and this was her treatment schedule. So she was actually given, if you can see that some of the pre-medication that was given to her was she had received some azathioprine and hydroxyurea, and the hydroxyurea is meant to suppress erythroid proliferation and to reduce the hyperplasia in order to create space for the donor stem cells. And the azathioprine was meant for immunosuppression. So she actually had a few complications post-transplant: neutropenic sepsis, titus media, trophomonas infection from her line, and cytomegalovirus reactivation. She engrafted her neutrophils on day 15, and platelet engraftment was delayed due to the CMV infection. And she was also treated with voriconazole for suspected fungal infection, and subsequently we also had to treat her for TB. Despite all of these, she achieved successful donor engraftment. Um, she was lost. So by 2017, she was stable. Her ferritin was 932. Unfortunately, she developed endocrine complications. She has primary amenorrhea, an absence of secondary sexual characteristics, and she's was commenced on hormonal therapy, but she discontinued her treatment. She is, unfortunately, some psychosocial issues that she does suffer from anxiety, and yeah, so despite all of this, she just did struggle a bit. So what these two cases actually illustrate is the evolution of thalassemia care in our province, whereas previously many of the patients were actually referred for transplant. And she was actually our first case that was transplanted in our unit. And I think importantly for us, the first case shows that, the progress that we've made, and we have a patient that's now surviving in almost into the sixth decade. And I think that is those two cases. So you can see that our whole purpose of actually presenting this is to show that there is hope. And yeah, then our last case is a case that I thought would be important. Jasmine actually mentioned to me that I should actually present this case. This was another Indian female. She was born in 1988. She was also treated by the pediatricians, and we inherited her into our clinic when she was about 13. She again was diagnosed about the age of 3, and she was transitioned earlier to XJADE as compared to the first patient. Her early course was notable for well-preserved cardiac and hepatic function, and she showed no deposition of iron. Unfortunately, at the age of 30, she fell pregnant unexpectedly, and we paused her chelation therapy for that period, and she continued to receive transfusions. We managed her with our multidisciplinary high-risk obstetric team, and at 37 weeks of gestation, she failed induction of labor and underwent a cesarean section. The baby actually had a good APGAR, but still required care in the nursery for a bit. Um, so I think for the purpose of time, I'm just going to stop here, um, to show that we've actually managed to get this patient through her pregnancy, and she delivered a healthy baby. But just some important points about thalassemia in pregnancy is that, it's important to actually emphasize counseling and counsel patients about pregnancy and genetic counseling. And if the patient has to fall pregnant, to actually involve your MDT. And yeah, so I think I will stop here because Jasmine has quite a lot of slides, and we can take questions on these cases at the end if you wish. So Jasmine, I've stopped sharing.
Thanks, Charlene. Before I proceed, I just want to check if everyone can see my
Yes, we
slide.
can.
Okay. Good afternoon, colleagues, and thank you for the opportunity to be here and to present. I'm quite honored to present on the Deep Dive platform. And I realized my first presentation with Deep Dive was about 6 years ago when I just started in hematology as a reg. So today I'm presenting all things thalassemia from transfusion to transformation. Okay. Just as an introduction to thalassemia, it emanates from a Greek word referring to thalassa, which actually means sea. And this so beautifully highlights the epidemiological distribution of patients with thalassemia who are located along what we refer to as the thalassemic belt, which surrounds the Mediterranean Sea and places such as the Cyprus, Southeast Asia, etc. So, although it is a monogenic inherited disorder resulting from an imbalance of either the alpha or beta globin chains, this then results in ineffective erythropoiesis and chronic hemolysis. What I really want to drive home today is that there's diversification and clinical heterogeneity amongst patients with thalassemia, even if they have a similar genetic phenotype amongst patients within the same family, there's quite significant diversification. So ideally, we want to manage these patients curatively with a hematopoietic stem cell transplant, but the reality is that this is not always offered within everyone's setting, as we don't always have matched related donors. So ideally, then we would offer these patients supportive care, and this would include, for example, a supportive transfusion, iron chelation therapy, early identification and recognition of the complications, and the management thereafter. So in today's presentation, I'm going to go through an overview into thalassemia, unpacking the disease biology with a focus on the epidemiology and looking at the clinical manifestations and the heterogeneity. And then how do we entertain the diagnosis, as well as what supportive and specific care can we offer the patients with a focus on iron chelation as well as the complications. I then lastly will touch on novel therapies and not just mention them, highlight what we have available in the South African context, as well as hematopoietic stem cell transplant and the role that iron and iron overload has on hematopoietic stem cell transplant. So, in terms of the epidemiological data, more than 40,000 babies are born annually with beta thalassemia, and this is a global statistic. 1.5% of the world's population are carriers, and the selective pressure of Plasmodium falciparum results in the genetic propensity within certain regions. So, for example, as I mentioned earlier, the thalassemic belt comprises of the Maldives, Cyprus, Sardinia, and Southeast Asia. But we also find thalassemic patients in Africa, in Australia, in America. And as Charlene so wonderfully highlighted, that this reflects the distribution of populations as a result of intermarriage between ethnicities, as well as the migratory pattern. Another point that I really want to stress is there's a paucity of data within the South African context. So the first publication was in 1983 by R.P. Bonafed, and she described within Cape Town, there's a specific Greek population that carries a risk of thalassemia. And then in 2013, the University of Witwatersrand published by A. Kraus, a particular study that looked at the epidemiological data and focused on the prevalence of thalassemia found in the Indian and Mediterranean population. And I think this is a very important point because not all patients with a hyperchromic and microcytic anemia equal iron deficiency. It's always important to look at the family history, the clinical presentation, and importantly, the ethnicity of the patient. So in terms of the South African statistics, beta thalassemias carry approximately 1.2% of the population. But once again, this is an old statistic, and I do stress the necessity of publishing our local data. So this is a very well-known diagram, and it was published in Barbara Bain as well. But what it highlights essentially is the genetics and the globin synthesis over time. So we know that on the short arm of chromosome 16 and chromosome 11, this is where we get the synthesis of alpha globin clusters and beta globin clusters. So initially, it starts off at the alpha locus control region, which is also referred to as HS40. And as a result of certain transcriptional factors and epigenetic modifiers, we get different alpha and beta globin chains synthesized throughout life. So initially in the yolk sac, for the first 8 weeks, we would get 2 zeta and 2 epsilon sacs, or rather globin chains, and thereafter we get 2 alpha and 2 epsilon globin chains. After 8 weeks, we get a fetal hemoglobin, and this, I'm just going to put my pointer on. Okay, and then this is referred to as 2 alpha and 2 gamma globin chains. This particular fetal hemoglobin then decreases, and we find that it nadirs 12 months after birth. And this is the ideal time to test for hemoglobinopathy, because we get that ideal switch from the fetal to the adult hemoglobin. And this is driven by the transcriptional factor BCL11A. And why I highlight this is that it has a therapeutic implication, in that when we use gene therapy, we can knock out this particular gene, because when this gene gets upregulated, it suppresses fetal hemoglobin, and it causes our adult hemoglobin to be synthesized, which is 2 alpha and 2 beta units. So if we knock out this particular gene, we get more production of fetal hemoglobin, and this might be helpful in patients who cannot on their own synthesize healthy beta globin chains. Okay, so this is a wonderful schematic highlighting ineffective erythropoiesis and iron loading. We know that in patients with thalassemia, especially the transfusion-dependent thalassemias, they need iron in order to survive, or rather they need transfusion in order to survive. So with each unit of blood, there's about 250 milligrams of iron, or approximately 0.8 milligrams per mole. But in addition to the exogenous iron that they will receive, the endogenous iron that they store is as a result of the ineffective erythropoiesis. So when there is an imbalance between either the alpha or the beta globin chains, we get something called hemichromes. And hemichromes are insoluble. They are under influence of extravascular hemolysis by macrophages. Iron within the macrophages are then stored in ferritin and leave the cell through ferroportin. It's important to note that the hepcidin levels in a patient with thalassemia are actually normal, can be also low. So part of the treatment to increase hepcidin levels would be, for example, by using Tempris S6, which increases, when inhibited, increases the production of hepcidin. And what the role of hepcidin would be in thalassemia is to block ferroportin and to keep iron trapped within the macrophages and to not be released. Because when iron is released in the process of ineffective erythropoiesis, transferrin is saturated, it's usually more than 80%. So then iron becomes part of this non-transferrin bound labile pool. And this pool is very important because it is this pool that creates the reactive oxygen species and causes the tissue damage that we find in thalassemia. I always tell my patients that when you miss 1 to 2 tablets, it has such a significant bearing on your iron, because it actually increases your non-transferrin bound iron significantly. So iron is then bound to citrate. It should be bound to transferrin, but when transferrin is saturated, it then gets bound to citrate and then readily gets transferred from the ferric form, which is the safer form of iron, to the ferrous form, which is the form that creates those reactive oxygen species. Iron then enters the cell through either the zinc transporter or the LTCC, which stands for the L-type calcium channel. And this is how we get the deposition of iron within the tissues. So you ask yourself, which organs are affected first? Can we tell? But generally, it is the liver iron that gets stored first because that's where our macrophages are found. Thereafter, it would be the endocrine organs. And lastly, it is the heart. But generally, this is variable according to each patient. It takes about 3 to 10 years in order to form iron deposition in the heart, for example. So this is a wonderful flow diagram which highlights the pathobiology. When we have an excess of globin chains or an imbalance, we get ineffective erythropoiesis. So how do we target the imbalance of globin chains? We can increase fetal hemoglobin, and this can be achieved through hydroxyurea, which I'm going to discuss later, that the clinical utility of hydroxyurea is not well established for long-term usage. And then gene therapy or gene editing can be helpful in either increasing the deficient globin chain, for example, the beta globin chain, or gene editing can be helpful in knocking out, for example, BCL11A, which would then increase fetal hemoglobin. So ineffective erythropoiesis can be targeted through ruxolitinib, sotatercept, or luspatercept, which I'm going to discuss as well later on. And then after ineffective erythropoiesis occurs, the patients develop anemia as a result of the chronic extravascular hemolysis, and this can be targeted through blood transfusions. But we know that blood and blood-related products are not without complications as well. The dysregulated iron and iron overload can also be targeted through iron chelation therapy, mini hepcidins, and as I mentioned earlier, Tempress S6 inhibitors, which would then increase hepcidin and allow iron to be trapped within macrophages and not be released. As a result of this whole complex process, we get ineffective erythropoiesis and extramedullary hematopoiesis. So as a result, patients develop splenomegaly, skeletal deformities, such as frontal bossing, osteopenia, and osteoporosis. And then largely because of the extravascular hemolysis, nitric oxide becomes sequestered. And these patients are often prone to thrombosis, portal hypertension, and leg ulcers. And as a result of the excess iron overload, eventually these patients will develop endocrinopathies, liver disease, and heart disease. And this is ideally what we want to prevent long term. So once again, highlighting that the genotype affects the phenotype. We have two types of thalassemias. We have transfusion dependent or non-transfusion dependent thalassemia. So the definition of a transfusion dependent thalassemia is one that requires a unit of blood approximately 3 to 5 weekly in order to maintain a pre-transfusion hemoglobin of more than 9 grams per deciliter. So thalassemias can be trays, they can be intermediates, or they can be a thal major. So the thalassemic trays often get underdiagnosed as iron deficiency. So it is this cohort that we need to spend extra time looking at the clinical history, the ethnicity, the family history, family studies, and then coupled with the laboratory investigations, which would include, for example, looking at the degree of anemia, looking at the Mensa index, which is calculated as the MCV divided by the RCC, and a value of 13. But we're going to look also at the sensitivity and specificity of this particular calculation. In addition to this, we would look at the RDW, RCC, but it's always important to do detailed iron studies in this cohort of patients. Then thalassemia intermediates often present with chronic hemolysis, but here the anemia is somewhat compensated for, and they have an anemia of approximately between 8 to 9 grams per deciliter. They often do hemolyze in states of stress or crises, such as aplastic crises or hyperhemolysis. And the genotype in this instance would be an HBH, for example, an alpha thalassemia, or a homozygous beta thalassemia. Our thalassemia majors, and this is where the bulk of our talk will be focused on, they present with a severe uncompensated hemolysis, transfusion dependency, and present with features in childhood, such as failure to thrive, hemolysis, extramedullary hematopoiesis, and their genotype is often a homozygous beta naught thalassemia. Okay, so highlighting that the genotype does influence the clinical phenotype, there's also a concept of modifiers, such as secondary and tertiary modifiers. So secondary modifiers basically control the balance between either the alpha or beta globin chain, and it could be as a result of compound heterozygosity and inheritance. And then tertiary modifiers are the way the clinical phenotype is influenced, for example, by bilirubin metabolism, iron hemostasis, infection risk, and malaria risk. So it is the combination of the secondary and tertiary modifiers that create the clinical phenotype in the patients. And now we can understand why there's such diversification and clinical heterogeneity amongst patients, even with the same genotypes. So if we just look at the beta thalassemias, for example, heterozygous beta naught or a beta plus thalassemia often are asymptomatic. The hemoglobin can be normal or slightly low, but here we would look at the MCV, which can be low. The hemoglobin A2, so if we look at our separation, our hemoglobin separation fractions, the percentage of hemoglobin A2, which is your alpha 2 and delta 2 subunit, can be increased. The hemoglobin F can be normal, and the hemoglobin A percentage is often normal. So here we would look at the Mensa index. As I mentioned earlier, it's looking at the MCV divided by the RCC. So if we find the Mensa index is under 13, it is suggestive of a thalassemia trait. With respect to homozygous beta plus, they often present as a thalassemia intermedia or even a major. The hemoglobin is low and the MCV can be low as well. But looking at the percentage of the HbA percentage is where we can help clench the diagnosis here. It's often between 10 to 30%, versus in our thalassemia major or transfusion-dependent thalassemias, they pretty much have 0% of adult hemoglobin. So how do these patients present? We're talking about our transfusion-dependent thalassemias. They often present with pallor, progressive anemia, failure to thrive in children, and signs of cardiac failure, which can be quite subtle in infants, for example, sweating, difficulty feeding, extramedullary hematopoiesis, which can be present as a splenomegaly or, for example, bony changes with frontal bossing or maxillary hyperplasia. Often these patients do have recurrent infections and states of hypercoagulability as a result of venous thrombosis. So I wanted to intertwine some of the ASH education publications from December last year into my talk, just as an update, especially targeted at the fellows who are preparing for exams. And this was an interesting article published in December last year in the ASH education book, and it was titled Thalassemia and Hypercoagulability. The article described that thrombosis is more prevalent in the non-transfusion dependent thalassemias because they have circulating pathological red blood cells, and it's up to 4-fold increase. They often present more with venous than arterial thrombosis, and they went through the clinical risk factors as well as the pathophysiological mechanism behind those clinical risk factors. So for example, if the patient has a ferritin more than 800 or a liver iron of more than 5 milligrams of iron per gram, this increases the risk of thrombosis because of the reactive oxygen species. They noted if the hemoglobin was less than 9, this is an increased risk of thrombosis because of ineffective erythropoiesis. And they also noted if the patient's over 35 years of age and has had a splenectomy, it increases the thrombotic risk, particularly splenectomy on its own has the highest risk of thrombosis. And the reason behind this is that there's circulating abnormal platelets, there's a thrombocytosis, there's abnormal erythroid cells as well. And then transfusion naivety also is associated with increased risk of thrombosis as a result of the abnormal circulating erythroid cells with abnormalities. For example, they express more phosphatidylserine on the outer membrane of the red cell, which is negatively charged and at an increased risk of thrombosis. We also note that high nucleated red cell counts are associated with thrombosis, as well as a thrombocytosis of more than 500. So this is a wonderful schematic just highlighting essentially what I said, and it goes through the pathophysiology of thrombosis in thalassemia. And we find that it's as a result of the red cell abnormalities because of the reactive oxygen species, the negatively charged surface area because of the presence of phosphatidylserine, the release of microparticles, and tissue factor. The ferrous form of iron also releases reactive oxygen species and causes membrane damage. The platelets, because there's a thrombocytosis, there's increase in aggregation, there's increase in activation markers, all as a result cause thrombosis. And then certain drugs. Later on, we're going to discuss luspatercept, but it's also been implicated in causing thrombosis, although a treatment for thalassemia as well. And this is because it increases the red cell mass and therefore increases the viscosity of blood. And then other factors which are prone to thrombosis includes cardiac dysfunction, liver dysfunction, endocrine disease. And then don't forget the endothelium. It's very important because of the activation of circulating endothelial cells, soluble markers, selectins, ICAMs, etc., that cause endothelial dysfunction. And then as a result of extravascular hemolysis, we get sequestration of nitric oxide, and this causes an alteration in vasomotor tone. It alters endothelial expression as well as adhesion markers and activates platelets. So it is this complex combination of all these factors that cause the hypercoagulability in thalassemia. The article then went on to create a scoring system for thalassemia and the risk of thrombosis. They also highlight that, and this is also in line with the International Federation guidelines in thalassemia, that when the patient has a thrombosis, it needs to be managed according to the recommended thrombotic guidelines. So there's no specific guidelines for thrombosis management in thalassemia. However, the score, the utility of the score is that it highlights the degree, or rather the risk, of a first-time thrombosis in patients over 10 years of age. And it is a dynamic score, meaning you can use it at any time, but particularly must be used when the thrombotic risk changes. So for example, if the patient's had a splenectomy, patient is postpartum, or there's now a metabolic phenotype that the patient develops, you can then employ the utility of these thrombotic scores. So if we look at the thrombotic score, it is risked according to low risk, which is a score of less than 9.5. High risk is a score of more than 13.5, and intermediate is between. So some of the characteristics which comprise the score would be a splenectomized patient. So this score is highest, followed by a patient who has not received transfusion. Then we have a patient who's over the age of 35 and a hemoglobin less than 9. And lastly, a ferritin of more than 1,000. And why, you may ask, why is it that the ferritin is not scored very highly? Is because a single ferritin that is high is not indicative of your total iron overload. And later on, we're going to discuss the utility, the sensitivity, and the significance of measuring ferritin. Okay, so how do we make the diagnosis of a patient with thalassemia? It's always important to start off with family history, clinical exam, and importantly, to highlight the ethnicity of the patient, coupled with our laboratory investigations, which would include a full blood count, looking at the degree of anemia, calculating the Mensa index, which is the MCV, divided by the RCC. This has a sensitivity of about 98% and a specificity of 82% respectively. One would also look at the red cell count, which is increased in thalassemia, and the RDW, which is usually increased in iron deficiency. Then looking at the peripheral blood morphology, we see this abundance of target cells because of the increase in membrane with a decrease of hemoglobin. We also see features of increased red cell turnover. So we see nucleated red blood cells and polychromasia. And if a patient's been splenectomized, we would also see a reactive thrombocytosis. The guidelines strongly recommend that all patients with a microcytic anemia need to have iron studies. So here we would look at each of the iron parameters, the serum iron, focusing on the ferritin, because we know that when the ferritin is over 1,000, we should be starting the patients on iron chelation if they are transfused. We look at the total iron binding capacity, which is often low, but would be high in iron deficiency. And we look at the transferrin saturation, which is high in thalassemia, and it would be low in iron deficiency. The guidelines also recommend using two methods of hemoglobin separation techniques. So we would use either gel electrophoresis, capillary electrophoresis, HPLC, whatever is available within your setting. And the ancillary investigations would include, for example, a supravital stain for looking at HBH disease and looking at the beta-4 precipitates, which appear as somewhat like a golf ball. And there's also a role for genetic testing and radiological studies. So just looking at the radiological investigations, we would do a skull X-ray. And classically, what we see is a hair-on-end appearance. And we see these vertical striations. And what they are actually is expansion of the marrow spaces as a result of extramedullary hematopoiesis. We also see widening of the diploic space, which is the spongy cancellous bone, and this appears as a darkened band. We see thinning of the outer cortices and frontal bossing, which we can also appreciate phenotypically when looking at the patients. So what we also see is prominent cheekbones, and this is as a result of the expansion of the paranasal sinuses, and classically the patients are described as chipmunk faces. We also see features of osteopenia, osteoporosis, but ideally you want to do a DEXA or a bone density scan, and this is done and recommended every 18 months. We also see biconcave vertebrae, and interestingly, I haven't seen this in our cohort, but the literature does describe that they are paraspinal masses as a result of extramedullary hematopoiesis. So what about genetic testing? Do we do this in South Africa? Who do we offer it? So it is done in South Africa because in thalassemia, we have either point mutations, small deletions, insertions, but we also have complex cases where we have compound heterozygosity, and that's ideally where we want to use this testing platform. It's not routine, and it's only mainly used in cases of diagnostic uncertainty and also in patients who want to conceive. So for example, prenatal or pre-implantation testing, we would test the trophoblast, or whilst the patient is pregnant, we could do chorionic villus sampling at 11 to 13 weeks or at 16 to 20 weeks and amniocentesis. So unfortunately, the last patient that Charlene presented didn't give us the opportunity to test her. Unfortunately, her baby was born normally, but should she have wanted to conceive, we would have counseled her and possibly offered her this testing. So now we'll focus on the management of thalassemia. And ideally, you want to cure the patient. So we want to offer the patients a hematopoietic stem cell transplant as early as possible if there's a matched related donor. However, the reality is that most of us only have supportive care to offer the patients, which would include, for example, transfusional therapy, preventing the complications of iron overload, monitoring for that overload, and once complications have developed, to manage the complications. So just looking at blood and blood-related products, we often transfuse our transfusion-dependent thalassemias. And the purpose of transfusing them would be to prevent the extramedullary hematopoiesis, to prevent those skeletal changes, to support the physiological growth, particularly in children, and to decrease the thrombotic risk. But we always employ patient blood management principles. And for example, this would include educating the patient on alternatives to blood, always doing phenotypic matched blood. We genotype the patients once, and always revising the indications, the frequency, the type of blood products, and then monitoring the patients for complications thereafter. So the timing, when would we transfuse a patient? Generally between 3 to 5 weeks before 2 years of age. And the goal is to have a pre-transfusion hemoglobin of between 9 to 10.5 grams per deciliter. There are certain caveats to this in that if a patient has cardiac insufficiency, we would keep the hemoglobin slightly higher, between 11 to 12 grams. If the patient is pregnant or requires surgical intervention, we would keep the hemoglobin more than 10 grams per deciliter. And in those patients with a compound heterozygous HBE beta thal, they can have a lower threshold of between 6 to 7 grams per deciliter because they often only become symptomatic at a lower threshold. And lastly, in non-splenectomized patients, they often require more than 30% higher blood volumes compared to those that are splenectomized. So the guidelines are quite specific in that they mention the hemoglobin must be less than 7 grams per deciliter 2 weeks apart, provided you've excluded other causes of the anemia, such as a substrate deficiency, infections, bleeding, etc. Or a steady state of a hemoglobin less than 7 with any of the clinical parameters, for example, failure to thrive, extramedullary hematopoiesis, inappropriate feeding, developmental delay, cardiac failure, or increase in spleen size. Important to note that transfusions are not without complications. For example, transfusion-transmitted infections, alloimmunization. So with respect to alloimmunization, the literature suggests about 10 to 20% incidence, but this is quite variable. And then, of course, iron overload. So prior to transfusing a patient, you always want to do a full blood count, an extended phenotype, and a genotype is only done once. We would monitor the LFT. We would do annual viral serology to check for any transfusion-transmitted infections. We would do an hepatitis B, C, HIV, CMV, and a parvo PCR. We will also do a ferritin. So ferritin is gate kept by the Department of Chemistry, and we're only allowed to do it every 3 months, but this is also in line with the clinical guidelines. It's important to do matched phenotypic blood, especially for ABO, RH, and the CAL phenotype. What product would you give a transfused or transfusion-dependent thalassemic? So we often would give them a leukodepleted red cell concentrate that's less than 5 days old. And why it's leukodepleted, so remember the definition of leukodepleted is a white cell count less than 1 times 10 to the power of 6. We would do this either through, well, the blood bank does it through either pre-storage filtration or pre-transfusion filtration. And why we do this and we choose a leukodepleted product is because it prevents CMV infection, TRALI, hemolytic transfusion reactions, and HLA incompatibility. So generally in the pediatric cohort, we want to dose the blood according to the volume required, but we don't do this for the adult cohort. In the pediatric cohort, they would calculate the target hemoglobin of 14 grams per deciliter minus the actual hemoglobin times the weight in kilograms and times a cofactor. They do not want to exceed a hemoglobin of more than 14. And generally in pediatrics, you transfuse blood at 5 mL per kg per hour. But the proviso is if there's congestive cardiac failure, you want to give blood at a slower rate. And generally you can split the blood given over 2 weeks. So this is a publication by the 5th edition guidelines for the management of transfusion-dependent beta thalassemias. And I wanted to highlight here the most common complication of blood and blood products is a febrile hemolytic reactions. And they found that alloimmunization risk was about 2.1% compared to other literature, which suggests it can be higher between 10 to 20%. So with respect to iron, we note that in every unit of blood, there's about 250 milligrams of iron that is being exogenously infused into the patient. And when iron reaches a level of more than 12 to 24 grams of the total body iron, it starts to accumulate within organs. So the first organ that is involved is the liver. Then it's the endocrine system, and lastly, it's the heart. But once again, it's quite heterogeneous, and the rate of iron deposition varies between patients and it varies between organs. So it's important to note that early iron chelation therapy initiation is paramount. The goal of iron chelation therapy, so what we would use to remove iron is iron chelation therapy, and the goal is essentially to bound that non-transferrin bound iron pool, which I described earlier on in the talk. And it is removed through a shuttling effect. So if I use the example of, for example, deferiprone will enter into intracellularly and remove iron. It then shuttles the iron to another iron chelator or to transferrin. So the other iron chelator it would shuttle it to would include, for example, deferocyrox. So in that instance, we can use both iron chelators, and we're going to discuss when we use a single chelator and what is the clinical indications for dual iron chelator therapy. Generally, we would want to start iron chelation over the age of 12 months, and this is to prevent any ocular or ototoxicity that is associated with the treatment. The first line of therapy is X-Jade. We fortunately have Jade New in our setting, but it is the same compound, it's deferocyrox. But once again, when choosing an iron chelator, it must be patient-specific, tailored to the toxicity profile, to the type of iron you want to chelate and remove. And importantly, within your setting, it must be dependent on what is available. The goals, we would ideally aim for a ferritin of between 500 to 1,000 micrograms per liter. And once again, this must be monitored over 3 months. Liver iron, the target actually is to have a liver iron of less than 3 milligrams per gram of dry weight. And a cardiac MRI T2 star must be more than 20 milliseconds. But we're going to discuss this as well in greater detail. So when choosing an iron chelator, one needs to first optimize the dose of the current chelator. So, for example, you would look at drug-to-drug interactions, toxicity profiles, tolerability of the patient, compliance. And I know for a fact that my patients are not compliant because they do miss 1 to 2 tablets a week. And unfortunately, this increases that non-transferrin bound labile iron pool significantly and increases the reactive oxygen species, which I do counsel them on every single visit. So we would first do this for our patients, educate compliance, look at toxicities, look at drug-to-drug interactions. And if we find that on maximum doses, we're still not winning, we can use combination therapy. So for example, we can use deferocyrox, deferiprone, or deferoxamine, depending on the type of iron you want to draw out. So the combination therapy reduces ferritin, reduces the liver iron, improves the cardiac function, and reverses the cardiac failure. And this is particularly for deferiprone. And if you find that the MRI T2 star is under 10 seconds, some guidelines also say even under 6 milliseconds, then consider using deferoxamine and deferiprone together. So your IV and oral chelators together. So let's discuss the iron chelators in a bit more detail. I'm going to spend a bit of time looking at this because it's important not only for clinicians, but also for us to counsel the patients to recognize the toxicity when administering this treatment. So the first iron chelator that was developed was deferoxamine, which is so known as Desferal. It's a wonderful drug, and it's used mainly when there is extreme iron overload. For example, if your MRI T2 star is, for your cardiac MRI, is less than 6 milliseconds, you want to use an IV agent. The downside of Desferal or deferoxamine is that it is quite tedious to use. So one needs to use it subcutaneously or IV over 8 to 10 hours a night for 5 to 7 days of the week. So often patients, they don't want to be bothered with this. They would prefer to be on an oral agent. It has a very short half-life. It's very efficacious, and it excretes iron through the urinary or the fecal route. The main side effect here is that it causes sensory neural deafness. It causes visual changes, cataracts, retinopathies. So we do this annually. We screen our patients every year. We send them for hearing tests. We also send them for visual tests as well. One would need to monitor for growth retardation and looking at any growth restrictions or bony changes. It's documented that there's also an increased risk of infection with Yersinia and Klebsiella, as well as it causes renal impairment and pulmonary fibrosis. So once again, it's an excellent drug to use. It's just the practicalities of using it as a long infusion at night for so many days of the week. The next agent is deferriprone. So when I think about deferriprone, I think of the pericytes, the heart. It is dosed at 75 to 100 milligrams per kg in 3 divided doses. It has a longer half-life of 3 to 4 hours. And the wonderful thing about this drug is that it's excellent for removing heart iron overload. But the downside is that it causes this agranulocytosis, which unfortunately we cannot predict per patient, but the guidelines recommend that when the ANC, the absolute neutrophil count, drops less than 1.5, one needs to stop the drug and one can support the patient with GCSF if need be. So initially, when administering deferriprone, we would do a weekly full blood count, then it becomes 2 weekly and eventually monthly. Other side effects with deferriprone is that it causes a zinc deficiency, and across the board, all iron chelators are teratogenic. And then lastly, we have X-Jade, deferocyrox. We fortunately have Jade New, which is an enteric coat of X-Jade, but it still has the active formula of deferocyrox. And here it's dosed at 20 to 40 milligrams per kg per day. With X-Jade, it must be taken on an empty stomach. Compared to Jade New, because it's enteric coated, you can take it with food. It has a longer half-life, and the major side effects here includes the ocular and auditory toxicity, the gastrointestinal discomfort. So sometimes the patients do have abdominal pain, diarrhea, vomiting, and it can worsen the transaminitis. So here, we would dose the drug depending on the Child-Pugh classification. So for example, if the Child-Pugh classification is Child-Pugh B, we would give 50% of the dose. If it's Child-Pugh C, we would stop the dose completely. So once again, it is safe. It's safe in children from 1 to 2 years of age, and it's an oral administration. So fortunately, within Albert Lutuli, we have Jade New, which is an enteric coated formulation of deferocyrox. Its active ingredient is deferocyrox, and it's referred to as a FCT, which is a film-coated tablet. It was actually introduced in 2017, and fortunately can be taken with food. This was proven in the ELLIPSE trial, where they studied transfusion-dependent thalassemias over the age of 10 years of age, and they found that the adherence and tolerability was improved because it was an enteric coated formulation. So something I'm learning as a clinical hematology fellow is it's wonderful to know all the drugs, all the side effects, how they work, but it's very important to know, and more importantly, to know when exactly you're going to use the drug and how do you tailor the use of the drug compared to the biology that you're facing or the patient that you're encountering every day. So when would you start iron chelation? Generally, you want to start when the ferritin is more than 1,000 micrograms per liter or the number of transfused products. So this guideline mentions 10 to 12 transfusions. Some guidelines say 10 to 20. So depending on your local guideline as well as your ferritin, one would consider the utility of iron chelation. So we would start over 1 year of age and we would use X-Jade dosed at 20 to 30 milligrams per kg, or if the patient is amenable to desferal infusions, 20 to 40 milligrams per kg over 8 to 10 hours, 5 times a week. One would then monitor the toxicity profile, drug interactions, liver function, renal function, ferritins every 3 months. And then annually, you can do a ferri scan. So a ferri scan is more sensitive at looking at liver iron. It's more standardized compared to an MRI T2 star looking at the liver. The MRI T2 star also can assess the heart function, and this is done in patients over 10 years of age every year. Once again, looking at the ferritin, if we find that the ferritin is between 1,000 to 2,500 and the cardiac iron is between the T2 star is between 10 to 20 milliseconds, and the liver iron is between 7 to 15. So it's a moderate control of your iron. Assess your cardiac function, do an echo, do an ECG. If we find that there's normal cardiac function, you can then optimize the dose of deferocyrox to 40 milligrams per kg or increase deferriprone to 100 milligrams. So optimize your single oral agents. If you find that the heart really is not functioning well, then you could consider an intravenous form. So we would use deferoxamine at 50 milligrams per kg over 24 hours in combination with optimal doses of either deferriprone and deferoxamine. So that would be the recommendation. So what do you do now if you're not winning on single iron agents or single iron chelation agents? And I find that on a day-to-day clinical practice with our cohort of patients with thalassemia. So first of all, assess compliance. Mostly they will not be compliance. Look at the dose of the drug. Are you underdosing? Look at the drug-to-drug interactions. We cannot give, for example, deferocyrox with a PPI because they interact. Look at the toxicity profile. And once we've optimized all those factors, look at the MRI. If we find that the liver iron is not well controlled, consider intensifying deferoxamine, so that's IV or subcutaneous, or deferocyrox. For the heart, but if it's less than 20 milliseconds, can add deferiprone and optimize that dose. If the cardiac dysfunction is quite bad and the MRI T2 star is less than 10 milliseconds, add an intravenous form of iron chelation, so deferoxamine with optimal doses of deferiprone. So just looking at the ferritin and the sensitivity of the ferritin, we know that it's an acute phase reactant and it's not indicative of the total iron stores over time. So we have to combine ferritin with our MRI investigations, our radiological investigations. But looking at ferritin, they say that if the value is more than 2,500, it is associated with cardiac dysfunction. However, it's not directly correlation. There's no correlation with cardiac disease. However, if the ferritin level is high, this correlates well with liver iron toxicity, but not well with myocardial iron overload. So here for the assessment of liver iron, we would do either an R2 ferri scan. So what a ferri scan does is it looks at a pin echo sequencing and it measures the R2 relaxation rate. So it is more sensitive and standardized compared to an MRI T2 star looking at the liver. But an MRI T2 star can actually measure both liver and cardiac at the same time. So the principle, the T stands for Telsa or magnetic frequency, and the T2 stands for the horizontal axis. And what this technique does is it looks at the relaxation time of, for example, the heart. We find that iron shortens the relaxation time. So therefore, your MRI when there's cardiac dysfunction will be less than 10 milliseconds, or in very severe cases will be less than 6 milliseconds. They found that also a low MRI T2 star less than 20 milliseconds correlates well with an impaired left ventricular function and heart failure. So once again, the interval of scans will depend on what you have available within your setting, your budget, and of course, the severity of iron deposition as well. So previously, we would do a liver iron biopsy, and why this is no longer recommended is because there are certain provisos for the liver biopsy. One needs to have a 2.5 centimeter core. The weight of the biopsy needs to be 4 milligrams. And often because there's sampling error or there's focal sampling, it cannot be indicative of the total iron storage in the liver. So therefore, the ferri scan or the MRI T2 star is the most sensitive. Also to note that when biopsying the liver, there's a complication rate of 0.5%. So we find that a surrogate marker to test for liver dysfunction is to look at the ALT. They find that if the ALT is high, the recommendation is to repeat 2 weeks later. If it's high for 3 months, these are the following recommendations. Do a DIC screen. Do a viral serology for hepatitis A, B, and C, CMV. A liver biopsy is then recommended if the hepatitis C is positive, coupled with radiological investigations such as the ultrasound, the CT, or the ERCP. Just looking at the heart once again, it takes about 8 years for cardiac iron to develop. And this can present in a heterogeneous clinical presentation. For example, left ventricular failure, pulmonary hypertension, right ventricular dysfunction, or a high output cardiac state. So there are risk factors for the development of pulmonary hypertension. And this includes, for example, patients who have been splenectomized, patients who are frequently transfused, a history of thrombosis, or the severity of iron overload. But once again, the ferritin does not correlate well with cardiac iron, but does correlate well with liver iron. So I think that's a very important take-home point as well. And just to note that when that T2 star jumps less than 20 milliseconds, it's very concerning for left ventricular impairment. So in those instances, please do an echo and an ECG, and it should be performed annually in patients over the age of 10 years. So then looking at endocrinopathies as a complication, unfortunately, when endocrine organs become infiltrated with iron, it is irreversible. And this results in diabetes, hypothyroidism, hypoparathyroidism, hypogonadism, gonadal failure, and sterility, which we've appreciated, unfortunately, in a lot of our patients. And then later on, we're going to discuss osteoporosis and osteopenia in a little bit more detail. But once again, some of the complications include the bony abnormalities, a pigeon rib cage, maxillary hyperplasia, osteopenia, and osteoporosis. So the recommendations are to do DEXA scans every 18 months. And on the DEXA scan, we would look at the Z score. So if the Z score is between negative 1.5 and negative 2.5, this is defined as osteopenia. So what we would recommend in these patients is to go to the gym and do weight loading exercises, as well as we would supplement them with vitamin D and calcium. If unfortunately we find that the osteopenia is now developing osteoporosis, so the Z score is negative 2.5 and below, in these instances, we would give vitamin D, calcium, but also we would recommend a bisphosphonate. It's very important to note that bisphosphonates cannot be used long-term. They can only be used to a maximum of 5 years. And the mechanism in which the bisphosphonate works is that it is either apoptotic against osteoclasts or decreases the surface area that the osteoclasts work on. And very important to note, when giving patients bisphosphonates, please monitor for osteosclerosis because often they can develop fragility fractures as well. There are other drug classes besides bisphosphonates, such as rank ligand inhibitors, and denosumab is an example there. Other complications include splenomegaly, leg ulcers, cardiac failure, growth retardation, and an increased infection risk. So now you have a cohort of patients with thalassemia. How are you going to monitor them in your clinic? At each visit every month, you will do an FBC, liver function, U&E. Every 3 months, you would do a ferritin. And annually, you would look for transfusion-transmitted infections through viral serology, hepatitis B, C, HIV. Annually, over the age of 10, you need to screen for endocrinopathies through FSH, LH, testosterone, estrogen, parathyroid, vitamin D, TSH, T4, and then to do an OGTT, or we would do a fructosamine in our setting because of the presence of a transfusion. And then Ferry scans or MRI T2 stars are done annually over the age of 10 years of age. And we would also increase the frequency if we note that the T2 star is, for example, in the heart, is between 10 to 20 milliseconds or even less than 10 milliseconds. Then every 6 months, an MRI T2 star is recommended. Once again, looking for osteoporosis, so through a bone densitometry scan every 18 months. And very important to do a clinical Tanner staging over the age of 10 years every 6 months. At each visit, one should inquire with the patient about the menstrual history, the reproductive health, transfusion history, and then to look at the side effect toxicity profile of the iron chelators. It's also important to discuss the reproductive health with your patients because we do have a young cohort of patients as well. And we note that with the advent of iron chelation, thalassemic patients are living longer and want to have families and want to live a somewhat normal life. So we should offer them reproductive health counseling and the opportunity to be able to conceive as well. Every year, we should assess them for dental caries because they are prone to periodontal disease as well. Okay, so we've discussed the specific therapy, but the supportive care is very important in this a special cohort of patients. So always offer them psychological and supportive intervention. It's inspiring to note that our population of thalassemias have gone on to do so much. So the patient that Charlene actually presented, she's a lecturer in university, and a lot of the thalassemias hold a degree, they hold respectable professions, and they've gone on to be quite successful in their life. So it's quite inspiring. So every year I should offer them dental care by assessing the dental caries for the periodontal disease as well, nutritional support through zinc, vitamin D, calcium, and vitamin E supplementation, education and genetic counseling, because as I mentioned, they do want to conceive and have normal families. So within South Africa, we do have certain bodies that offer support to these patients, and they include the South African Thalassaemia Association, Rare Diseases of South Africa Inherited Disorders Association, and there are other international organizations as well. So some contentious supportive care includes, for example, hydroxyurea. Is there a role of hydroxyurea? We know that it increases fetal hemoglobin, but in small studies, the results have been inconsistent with the efficacy rate of between 30 to 70%. It has shown a decline in response over time, over long-term usage. So therefore, we don't recommend using hydroxyurea. We use this commonly, though, in sickle cell disease. Splenectomy, the role for splenectomy is no longer as appreciated or recommended, rather. But it is recommended if the patient has increase in spleen size, recurrent pain, and the transfusion dependency is worsening. Therefore, we would counsel the patients that there are significant complications associated with a splenectomy. For example, there's a 4 to 7 risk of thrombosis. There's an increase in pulmonary hypertension, OPSI, or the risk of sepsis. Okay, and then lastly, ending off with hematopoietic stem cell transplant. The last patient that Charlene did present, fortunately, was offered a hematopoietic stem cell transplant. And in our thalassaemic cohort, we have transplanted 2 of our patients. The data, according to the European statistic, is that there's a 90% survival. And often these patients 2 years later are disease-free at a rate of more than 80%. It improves the quality of life versus just the supportive care of transfusion and iron chelation. But overall, the mortality is risked at 12% within 2 years of the transplant, and that largely relates to the myeloablative conditioning regimes, the graft versus host disease, and the graft failure. It's best to transplant these patients under the age of 14 years. The earlier the age, the better, in order to prevent the complications of the iron overload, because we know that non-transferrin bound iron releases toxic reactive oxygen species and damages organs. The risk factors include, for example, hepatomegaly, liver fibrosis, inadequate iron chelation, and those who are over the age of 6. So we note that ferritin is not a significant marker in highlighting the disease of iron burden because it is quite a labile marker. So we would use, for example, the MRI T2 star and the Ferri scan. But iron itself, and this is a wonderful diagram which highlights the significance that iron plays on the stem cell. And I wanted to ask this as a question to the audience, whether they routinely test for iron overload pre-transplant of any of their hematopoietic stem cell transplant, because a high iron level as a result of, for example, transfusions in MDS is associated with increased risk of GVHD infections, delayed engraftment. It causes stem cell exhaustion, stem cell apoptosis, and it weakens the B and T cell engraftment. So can we improve the iron metabolism or reverse the tissue damage once we've transplanted the patient? A reversal has been documented, but once again, a patient needs to be compliant completely to the iron chelation. But having a patient who's iron overloaded is not a contraindication to offering them a transplant. Okay, so we're going to look at some of the novel therapies, and I wanted to highlight that not all these novel therapies are available within the South African setting. So we shouldn't look at what's novel, but rather what is available. So the first drug of choice is luspatercept, And how luspatercept works is it binds to the transforming growth factor beta family, and it is a specific binder. It was studied in the BELIEVE trial, and 21% of adults showed a 33% reduction in the transfusion requirements as per the use of luspatercept. So what it does is it binds to transforming growth factor beta, and it allows this late erythropoiesis to occur, therefore increasing the red cell mass. Therefore, it's also associated with a risk of thrombosis. The JAK2 inhibitors have been studied, and for example, ruxolitinib shows an improvement in ineffective erythropoiesis by decreasing the splenomegaly, but it was not associated with a difference in pre-transfusion hemoglobin. Many hepcidins as well as Tempris S6 have been studied to increase hepcidin level and therefore block iron from being released through ferroportin. And then also we have studied hemoglobin, the fetal hemoglobin induces, for example, hydroxyurea, hypomethylating agents, and short-chain fatty acids. I wanted to highlight here that the utility of ruxolitinib was studied in a phase 2 study and looked at the oral administration of 10 milligrams twice a day. It reduced the spleen volume, but had no efficacy on the hemoglobin level. And then the other transforming growth factor beta binder is a sotatercept, which has also been studied. Okay, looking at pregnancy and fertility. So Charlene presented the last patient who was pregnant. We only found out at 24 weeks that she's pregnant. And unfortunately, she had been exposed to an iron chelator for the bulk of her pregnancy. Fortunately, did deliver a healthy baby. But should she had come to us before she conceived, ideally, this is what we would have done for her. Looked at her heart function through an ECG, an echo, an MRI T2 star. Looked at the liver iron overload through a Ferri scan or an ultrasound. Looked at the endocrinopathy, for example, HbA1c, assess the thyroid, the parathyroid function, do a viral serology, look at the bone health, optimize her lifestyle through obviously stopping smoking and alcohol consumption, and then reviewing her medication history. So if your patient falls pregnant or would like to conceive, stop the iron chelator. It can be, however, resumed in the second trimester onwards if necessary, but ideally should be started or restarted after breastfeeding. Maintain the pre-transfusion hemoglobin of more than 10 grams per deciliter. In a non-transfusion dependent thalassemia, you can have a hemoglobin of around about 8 grams per deciliter. And it's important to note the thrombotic risk is highest postpartum, so consider low molecular weight heparin until 6 weeks postpartum, and then monitor for fetal complications, as Charlene did say, with an MDT and high-risk obstetrics. The delivery plan is not specific for patients with thalassemia. It should be according to obstetric indications, but always ensure that there's cross-matched phenotypic blood that is available. Okay, so that concludes my talk, and from seed to survival, I'd like to end off by saying that the lifelong management of beta thalassemia remains a huge global burden, especially in resource-constrained settings, which is what we face every day. More work is needed to achieve effective control, and I stress the urgency and need for publications as well in terms of our local setting. Early initiation is needed to prevent lifelong sequelae, and it's hoped that new approaches will reduce symptoms, quality of life, and long-term clinical outcomes. So I leave you with one word, and that word is THAL. The T stands for treat early. The H is to halt expansion. A is to advance innovation. And L, lastly, to lengthen life. So thank you for your attention, and I'd like to acknowledge my wonderful department.
Thank you so much, Jasmine, for the wonderful presentation, and it was in depth, and I think it's really beneficial to the audience, especially those that may not be exposed to thalassemia patients. Before I open for questions, I just want to go through some of the comments Jacques has made. So He says here, not sure if it was mentioned, but for fellows or registrars, remember about the role that erythroferrone plays in iron overload of thalassemia and other forms of ineffective erythropoiesis. And Jacques is right there. I don't know whether you mentioned it, Jasmine, but he correctly says that it's an important um, to remember. And then apart from macrophage ion trapping, I would expect that hepcidomimetic stroke stimulants will also lead to reduced ion absorption. Yeah, so that is as well. Hepcidin restore the hepcidin signal. So I think it is also correct what he's saying there. And he also says ferritin underestimates iron loading in non transfusion dependent thalassemia, and it's recommended that liver iron MRI be used preferentially to decide if iron chelation is needed in these patients. If MRI is not available, can use ferritin, but recommend cut-offs therapy to start above 800 and not 1000 as is in transfusion dependent thalassemias. Yeah, so, unfortunately, with the program having stopped, challenges now are getting those scans actually interpreted. And you know, I think in our setting, we need to engage with the radiology departments within our hospitals to see if they have the software and then the expertise to actually um, do these T2 stars and fairy scans and interpret them for us. I found them extremely useful in our patients, so I think it's important to have. And then Estelle says, yes, we do ferritin before all transplants. Just note that ferritin can be used as a marker of difficult to treat malignancies, and as such, not a pure marker, but a mixed multifactorial marker of poor outcome. Yeah, so unfortunately, our experience with ferritin is it's an acute phase reactant, and interestingly, of our cohort, we currently the last time I checked, we had 31 patients that had come through our service over the years. Some may not be with us anymore or have moved away. But interestingly, the only one patient that we had who developed transfusion-associated HIV infection. She was one patient where prior to the having a ferry scan or MRI, her ferritins were sitting in 12,000, went up to 13,000 one time. So really, we couldn't say how bad her iron overload actually was until such times that we actually did the T2 star and ferry scan, and she had multiple infections associated with her HIV, and unfortunately he succumbed to the HIV complications eventually. So that was just one of our cases that I remember quite. It was a sad one. Um, let's see. There's another question here. Thank you for the excellent talk. Do any labs in South Africa offer genetic testing for alpha thalassemia? Eglin, I'm not sure. I don't know if anybody on the audience from the private labs may be able to answer that, or within the NHLS that might be doing a study. So if anybody can please unmute and give us some idea of the types of genetic testing being done for thalassemia in South Africa. I think Rita went off the call. She apologized. So I'm not certain if there's anyone from AMPATH Lancet that might be on. So there's no one that's actually volunteering. I just want to know if there's anybody else that wants to comment, if there are any of the pediatric treaters or anyone from the other centers in Johannesburg or Cape Town that may want to contribute some of their experience with the thalassemia populations in their areas. Okay, so it seems that nobody has any further questions. There's just one thing before, one last comment that I have to make is that in addition, we do run into trouble where patients develop red cell antibodies, and that becomes a problem with cross-matching. And in that case, patients actually come in much earlier to have the types and screens done, and we get as well. Sanbus tries to find us the most compatible. So we have a few patients that have developed red cell antibodies as well. Um, So in the absence of any other questions, I just want to thank Jasmine for all the effort she's put into her talk, and I really enjoyed learning all the new things as well, Jasmine. And there's another comment before. Jacques says we have a few in our center, unknown, one alpha thal and some betas. Oh, yes, sorry, one last thing is that, with the migration and marrying the cross marriage into different race groups, we found that we've have patients that actually have sickle thalassemia. So we've got small cohort of sickle thalassemia patients, and those patients actually they are at higher risk for thrombosis, and we've seen it where these patients have pulmonary emboli, DVT, and obviously these patients are more hotters than the patients with beta thalassemia major, and yeah, so and we do not transfuse them as often as you would a patient with thalassemia major. Anyway, so I'd like to wish everybody a good afternoon, and thank you for joining us. Next week, we have an international speaker, and we will see you all next week. Have a wonderful evening.